So as Reverend Sierra said, I work at the CU School of Medicine, and I'm an associate professor of both pediatrics and medicine, and I direct Colorado's adult and teen congenital heart disease program. So this is a program designed for kids and adults who are born with congenital heart disease, a little bit different than acquired heart disease. Again, I have no financial disclosures, and I do want to make it clear I am not an infectious disease expert, nor am I a pulmonary critical care physician. So I've been reading a lot about it, but not involved in the day-to-day care of many of our coronavirus patients. So what I thought would be important for this third talk and focus most of our time on is really the prevalence, mortality, and take a deeper dive into Colorado specific numbers. As Reverend Sierra mentioned, we're moving into what the Episcopal Church is calling season 2, and the state of Colorado as well, where we're no longer stay at home. The state of Colorado is calling it safer at home, but certainly more businesses, including possibly our church, are opening up. So we need to understand better, how can we live with COVID? What are the risks? What's going on? This is a brand new infection to humans. And so we as the medical community have been working, many people, many hours, trying to figure out how to deal with it, who's the most at risk, are there treatments, and so forth. And then I'll talk briefly about SARS-CoV-2, which is the official medical term for COVID-2. Just about facts of the virus and risk factors that I had reviewed at previous talks, but in case you weren't able to be there or you've forgotten. I will talk briefly about some treatments and vaccines, since there are some updates, but these are very modest updates. And then talk about, can we safely reopen our society, our churches? And I apologize, I had a busy week, so I didn't check all my spelling carefully enough. So our churches, not our out churches, and really the rest of our lives. And then I hope there's going to be questions, because I hope this is more of a dialogue, not just a lecture. So where are we now? So because we as medical providers, our lives are getting back to being fairly busy and a little busier than before, I had to skip coffee hour on Sunday, so I apologize. But I will be there this Sunday and start working on this talk. So I looked at numbers of cases, not from today or yesterday, but as of Sunday morning. And I've got links here that people, if they want to take a screenshot, or as Reverend Sierra said, will be available later. But so those URLs are websites where you can look and play with this data yourselves. So as of Sunday morning, there was just shy of 2 million cases of confirmed coronaviruses. Although, as we'll discuss in a bit, we think that number is likely a lot more. That's what was confirmed cases, and there's 109,000 deaths. When you look at what the mortality is from the data that we have now, it looks like it's about 5.7% mortality of those that are known to be infected. Now, we think this is still a higher mortality rate than is true, because early on, when the virus was spreading through all of our communities, we didn't have adequate tests. So the more mild infections were not being confirmed. We will have more data now that we have serology testing coming online in our communities now. So probably in a few months, we'll have a better estimation of what the mortality rate is. but this is where we are right now, 5.7%. And to give you context of other significant viruses in the community, typical seasonal influenza is about 0.5%. So here we're talking, this is 10 times higher mortality. We don't know if it's truly 10 times higher, but it is more severe than influenza. So in Colorado, as of Sunday, we had 27,848 confirmed cases. And I'll talk a little bit from our School of Public Health, how we think that number is probably closer to 150,000. But that's the confirmed cases. And we've had 1,527 deaths. So similar to the national average, about 5.5% mortality. But now, in the last, I would say about 4 to 6 weeks, we're now counting deaths as deaths among COVID cases or deaths that are believed to be secondary to COVID. Now, to me, I think among COVID cases is probably more important because the person died. And we know in my field of cardiology, the most common cause of death from influenza is triggering a heart attack or making heart failure worse. So, it depends on whether the coroner says they died from a heart attack or if it's COVID that triggered the heart attack. The person, unfortunately, still passed. When we look at Denver County numbers, so trying to get a little bit more granular and closer to home for our church family, there is 6,000 confirmed cases. So that's about 22% of our state infections. So certainly the largest number of infections of any county, with 339 deaths and a very similar mortality rate compared to the state and the rest of the country. Adams County, one of our counties to the east, of which many our church family lives, has 12% of the state infections, or 3,000, and slightly lower mortality of 3.8%, likely secondary to younger age demographics of that county. Arapahoe County, also to the east, had about 16% and a little bit more than Denver County of 7% death rate. So other websites you can play with, and I think very important as we're considering how to open our church, if we open our church, is this data on the bottom screen here of COVID-19 colorado.gov case data, which is what I pulled these from. So looking where we are, here we are in Denver County, by land, one of the smallest counties in Denver, but by population, the largest. And this rate looks at not the total number of infections, but the total number of infections per 100,000 people who live in that county. Why is that important? This just shows you how rampant and how active the spread is in those areas. And so you look at the counties which have the most spread, and that's Logan County to the northeast, followed by its neighbor, Morgan County. And you can imagine there's a large number of large industries, particularly the meat packing plants, that we learned didn't have adequate restrictions for personal protection, both gear, testing, as well as social distancing. And that led to large outbreaks there. We know that many of our mountain counties also had outbreaks, and this was because of, we believe, our earliest infections in Colorado started in these counties, and we didn't really have a good sense of social distancing and protection. So 3 of our very large counties are on the western slope, or the western side of the Continental Divide. So the counties most important to this discussion of our church family are Denver County, where we had 846 cases per 100,000, followed by Arapahoe County, 710 cases per 100,000, and Adams County, which was 694. To look at that in a different way, each of us process data a little bit differently. Here's a graph that the state of Colorado posts of which counties have the most spread, from the most on the left to the least on the right. And you can see Denver County here, not doing too bad, but certainly a lot more spread than the majority of counties. Well, who is getting affected within these counties? How is it affecting both racial and ethnic subgroups and by age? So looking on the left, you can see that the largest number of cases is in Hispanics, 3.7%. Even though on the right, you can see under Colorado, this is the percentage of the population that each group makes up. So Hispanic, all races, are about 22% of Colorado's population. Yet of our case total, they were 37%. Interestingly, they had a lower mortality rate, and this is likely secondary to younger age of the population that were out working, getting exposed. Very pertinent to what we all are feeling and hurting from in the last couple of weeks with ethnic, with the discrimination and standing up for all Black lives. African Americans make a much smaller percentage of Colorado's population, about 4%, but yet they had a higher percentage of infections, 5%, and it's still higher mortality rate of 6 points. So about twice, their death rate was twice percent of what their prevalence is in Colorado. And when you look at the largest number, white non-Hispanic, which makes up about 68% of our population, they made up about 33% of the cases, so only half of that population, but were the largest number of deaths. Looking at it differently, so the percentage, while we have had deaths in pediatrics, we've not had anyone die less than 10. And there's only been a couple in the adolescent age. But you can see the mortality goes up with advancing age. So those that are over 80 make up only 3% of our population, but are greater than 50% of the deaths in our state. Or looking at it a little bit differently, those older than 70 make up 9% of the population, but we're about 75%, 77% of the mortality. So again, the biggest risk factor we know for severe infection and not doing well is advanced age. And we can discuss that more. I've discussed it in previous meetings, my previous 2 meetings, of theories of why it's affecting the older population more severely. So this is a graph that is on the website that's showing the 3-day average of identified COVID cases in Colorado. Now, it's a little bit deceiving because early on, between March and early May, we didn't have a lot of tests. So we are testing more than 10 times that we did at this point. So we're identifying more patients. But what I want to show is, as of the average, the 3-day average of new new people identified with the COVID infection. This means recent infection. This is the nasal swab, not the antibody test. So new active infections. This shows that, in Colorado, there was this virus is still spreading. As of June 7th, we still had 251 new cases. That's different compared to 725 at the peak, but it is still spreading. It's not gone. Uh, when you look at the total number of cases cumulative within the state of Colorado, it's somewhat of a linear increase, meaning the disease is still spreading. And again, this it can be a little bit deceiving because we're identifying a lot more with more mild disease. This better represents that, where previously we were only testing people who were either healthcare workers or needed to be admitted or had a severe health condition that put them on. So we had very minimal testing. But now we're able to test just about anybody who may have symptoms. And the governor had said those that were at the protest and hence were not able to be socially distanced, he encouraged all of them to be tested. So we have ample tests now. So this looks at the number of hospitalized cases or people with COVID. And you look that the number was dramatically increasing by mid-April, and then it started to flatten off. And this is what you've been hearing on the news over and over of flattening the curve. So stay at home worked. We didn't have to hospitalize as many patients. So the number of patients being hospitalized in the last few weeks has dropped dramatically. So that's good. So we have more supplies and can care for people in other ways. And the mortality has dropped. Actually, in here, within the last 5 days, there was one day that we had nobody died from COVID. But here, it was about 2 days. 2 people died most recently, and about 39 per day at its peak. So this shows you that we are decreasing the spread. Fewer patients, fewer people are getting infected, particularly fewer vulnerable people, those that are in nursing homes or of older age that are not in nursing homes. So we're seeing less severe infections being admitted. This is a common graph which took me a little bit of time to understand and to understand the significance. So focus first on the bars of the bar graph, not the red line. So these are the number of cases identified each day of COVID. Now keep in mind, as I mentioned before, we had very little testing available. So the numbers were probably 5 to 10 times this. Now we're identifying larger numbers of patients, or we're able to test a larger number of patients than ever before. So these are not infections, these are tests that are being done. So you can see we're able to do about 8,000 tests per day. And in the beginning, only our state lab had the ability, but now our independent hospitals and other labs have the ability, and they're doing a lot more tests. What this red line shows you is on the right side, the positivity. So how many of the tests that we were doing were positive? We hope this number, in order to keep the control of this infection, is below 5% in order for us to open up, ideally closer to 2 or 3%. So early on, again, we had, of those that we were testing, about anywhere from 1/5 to 1/4 of the tests were positive, because we were testing highest risk and most symptomatic. Now that number has gone down to um, just above 2.5%. So this is why it is felt by public health experts we can open and do things together, although I'll show you with caution. So um, our School of Public Health has done some modeling. So as we're opening and restaurants are being open with less capacity, our churches may open, some throughout the community have opened already. Um, what can we expect? What is likely to happen? Now, epidemiologists say that their models are never accurate, but they're as accurate as possible. They're a prediction of what's to come based on the information we have. And so, a couple things that our School of Public Health, um, based on what we call mathematical modelings, noticed that because of inadequate testing the first few months, it is estimated that there's about 170,000 Coloradans that were infected. But that's only about 2.9% of our state. In order to really prevent significant spread, we need to be at 60 to 70% immune. That's either vaccine or previously infected, if infection um, does prevent against reinfection. We still don't know that. The drop in social distancing to 75%. So what does this mean? This took me a long time to understand as well. So our School of Public Health considers during our stay-at-home orders in March and April, we had about 85% social distancing, meaning they were still essential workers. The mail, people going to work at the hospitals, the grocery stores. So about 85% of us were able to really hunker down. 15% weren't. So during the social distancing safer at home, this has slowed the initial 80 to 85% social distancing really got us where we are. But the School of Public Health, with the recent expansion of activity between May 9th and May 14th, has showed that this decline in case number has slowed. I hate double negatives or double positives, but the rate of which the spread is decreasing at a much slower pace. So models predict that as social distancing becomes less prominent, such as 45%, despite measurements to reduce infection, such as face masks, this is going to lead to a surge, not surgery, in midsummer of sick people, possibly in excess of hospital capacity. And the models do show that mask wearing is beneficial and controlling the epidemic. So let me show you some slides that they have and what I was trying to explain. Perhaps in graphic representation, this will help. So this is from the Colorado School of Public Health. So the effective reproduction number of, this is what's called R naught or R0. So that is how many people who are infected with the virus are they going to infect. So early on, when we knew very little about this and they're going about their daily lives like they had a cold, it was about 4.5%. Then we went to mitigation of this. And then by mid-March, we went to stay at home. So the number of people, the R naught that each infected person was infecting had dropped below 1. And so this is what caused our numbers to drop across our state. However, what they're seeing is because of middle of May, as things are starting to open, this drop is starting to increase. And we think as more and more people are going to go out, this R naught will cross 1, so that for every one person that's infected, they may infect more than one other person. And so the spread is going to become potentially more exponential again. So they modeled different scenarios based on what if. And this is what it looks like. And I'll try to walk through this. Scenario one is if people of all ages start dropping the social distancing. So they go from the 80 to 85% that we see here in the orange to, let's say, 65% social distancing. So the number of infections are going to rise and are going to rise higher than they were during our peak. However, if people are more blasé and this drops to, let's say, 55, we're going to have a bigger spike than we had before. And again, 45% really high spike, 3 times what we had before. However, if, let's say, people at highest risk, above 60, maintain the high level of social distancing, so the 80 to 85% of stay home, going out maybe only for groceries, that will decrease this. Now, this is also total hospitalizations, because the School of Public Health, this isn't infections, this is hospitalizations, because this is, are we going to outstrip our ability to care for the ill? And so if those that had the higher hospitalization rate stayed home, this number would be much flatter. And so you can see here that it would be very similar to what it is now. Scenario 3 is if 50% of people over 60 maintain high levels of social distancing, but the other 50% really want to go out, then it depends on the degree of social distancing that's going to increase. It's a little confusing. The graph on the right shows the ICU needs, and this dotted line is Colorado's capacity of ICU. Well, what about masks? They look at different scenarios. Scenario 4 here assumed that social distancing has reduced to about 50%, but 80% of people wear masks. So the number that will mute the number of people who get sick and need to come to the hospital, if only 65% wear masks, that will go up. And if 50% wear masks, that'll be higher. So evidence based on modeling suggesting that masks do help. Well, what are the summaries from our colleagues at the School of Public Health? In all the scenarios that they modeled, the epidemic curve is rising by August 15th. So at the times that schools, colleges, and universities are reopening to a degree, based on our current practices in most scenarios, the next peak of infections will be greater than our prior peak in April. It's a little sobering to try to wrap our brains around. Adults older than 60 have accounted for approximately half the hospitalized COVID cases in the state since masks, but only about 21% of the population. So let me switch gears for a little bit and talk about some facts we know about the virus that haven't changed compared to my other talks. We know that the virus remains stable in aerosolized form when we cough or in secretions for about 3 hours in the air. And certainly activities such as forced coughing, singing can increase the distance that the virus can travel. It can remain stable on surfaces such as cardboard for about 24 hours, interesting on plastics and stainless steel for up to 3 days. The median incubation time from the time somebody is exposed to the time they develop symptoms is about 4 to 5 days. But it is felt by many that most will be contagious in shedding the virus before onset of symptoms. Now, it's a little worrisome that the World Health Organization made the comment that many of you had heard yesterday or the day before, that very few people have been infected before they were symptomatic. That was not the official stance of the World Health Organization. It was a member of the World Health Organization. And many folks feel that isn't really proven and that is unclear. What we also know is most people will develop symptoms once exposed, will develop it by about 12 days after their exposure. Those that are infected, 88%, the majority, vast majority, will eventually develop a fever at some point. Although fever can be a later sign, those that actually were hospitalized, only half of them had a fever at that time. About 2/3, 3/4 had cough, which is usually productive with sputum, runny nose, and gastrointestinal symptoms. And some have what we call anosmia, where they lose the sense of smell. We had an entire grand rounds on that last week, which was pretty interesting. What we know, about 80% will have mild, 24% will develop severe symptoms such as viral pneumonia, and 5% develop critical disease requiring high flow oxygen, ICU care, or other advanced care. Those with other medical issues have a higher chance of severe illness with an infection. And this goes along. As we get older, we start accruing medical illnesses such as a higher prevalence of hypertension, chronic lung disease from either infection, smoking, diabetes, or cardiac disease, acquired cardiac disease. So I want to switch to some positive notes, even though the models look worrisome. To date, when I talked to one of my colleagues Monday, who was one of the ICU doctors working in our COVID ICU. So what happens at the hospitals, they isolate units where suspected or known COVID patients go to prevent spread to other patients who get elective for surgeries or other needs for admission. So on the COVID unit, it is believed at University Hospital that no provider, nurse, physician, respiratory therapist got infected from work on the COVID units. So we can protect ourselves despite being exposed to even some of the sickers or the sicker. The pillars for protecting against infection are multiple. It's not just a mask. As most folks will say, a cloth mask will only do so much in protecting you from infection. It's more you are trying to protect your neighbors from infection. But face masks help decrease the spread. Social distancing clearly helped when we looked at the number of spread. Frequent hand washing helps for 20 seconds or more, or using an alcohol-based hand cleanser, of which 60% of it should be alcohol-based. Meticulous cleaning of surfaces, and particularly in areas like restaurants or grocery stores that have been exposed to multiple people. Quarantine when exposed, and I say when exposed without proper personal protective equipment. So those in the hospital, if they're taking all these measurements, they weren't getting sick. Now, contact tracing is something that our state is going to be starting, not nearly to the extent that countries such as Singapore, South Korea, and China had implemented, but hopefully this will also decrease the spread. So what about treatments? What do we know about treatments today? Well, the treatment that got the most press early on was hydroxychloroquine and chloroquine. What are these medications? They've been used for decades based on a bark from a tree identified initially in South America that it decreased malaria. After been using these for many decades, it was also learned that it affects our immune system. And so autoimmune processes such as rheumatoid arthritis or lupus, these helped many of these patients. Early on in animal models, it was shown that these medications inhibit viral replication. So they sounded like they were going to be the next best thing since sliced bread. Early human case series, small case series, also suggested that it decreased the time of viral shedding in symptomatic patients. But many in the medical field have looked back at this study and saw there was lots and lots of flaws, very small study in the way it was done. So the early press that it got was very good. But this medication has side effects. It can cause bone marrow suppression, so your blood counts go down. It can cause electrical changes in your heart called prolongation of a QT interval, which can increase your risk for dangerous heart rhythms or fatal rhythms. So when we looked at larger trials, now this is not what we call a randomized controlled trial. Why is this important? I'm giving you a lesson in medical trials. Randomized controlled trials are the only way we can prove a treatment is effective. What does that mean? That means you give a group of people the treatment and a group of people a sugar pill or placebo. And you randomly assign people to one group or the other. And that shows whether a medication is effective or not. So we only have one randomized controlled trial that I'm going to show you of another drug. So we don't have, the data is still out on this medication. But this was a large trial looking at patients in New York City of over 1,000 people, what we call an observational study, which looked at those people, 735, who had hydroxychloroquine and another antibiotic called azithromycin, which was believed in animals to work what we call synergistically together. And then just erythromycin alone. So what this is called is the Kaplan-Meier survival curve. Or in this case, mortality. So higher is worse, lower mortality is better. So those that were on hydroxychloroquine and azithromycin with the COVID infection, more died than those that were not taking hydroxychloroquine. Now, this is not proof that the medication is particularly harmful, nor is it not helpful. It suggests it's not helpful. So the more robust data that we have, not as strong. So to date, it suggests it's not effective. There was a randomized controlled trial that was done on looking at healthcare workers who were exposed without adequate protection, who took hydroxychloroquine. Half of them did and half of them didn't. And it looked like there was no difference in the rate of infection. So that was a randomized controlled trial on prophylaxis with this medication, and that was negative. Well, we do have a medication that has been shown to be effective in what we call a randomized controlled trial. And this medication is called remdesivir. So remdesivir is an antiviral agent. It's been used for other agents, I believe cholera, but don't quote me on that, where they randomize 1,000 patients with COVID to either receive this intravenous remdesivir versus placebo or salt water. And they looked at the median time to recovery was 11 days in the remdesivir group compared to 15 days in the placebo group. So they stopped the trial early because this was a signal that it was beneficial. With the trial being stopped early, the mortality, while looks like it was less in the remdesivir group compared to placebo, 7% versus 11%, just missed what we call statistical significance. Again, I apologize for my spelling errors. Um, uh, so it does look like it's effective, at least in some ways, as far as shortening the course of the illness. So we have something. There's many other medications that are still being studied, and well over 200 trials, many of them randomized controlled trials looking at, including other antivirals called lopinavir, nortinavir. We'll see it, that are used for HIV. We'll see if those are also effective versus this, and ribavirin. We're also looking at, we know that people are getting this autoimmune process after the infection. And so these are antibodies that are being given to very ill patients that dampen their immune system. And we don't have any data whether or not this is going to be benefit or not, but we have ongoing trials. Other things you've heard in the news, Colorado was one of the first to do this. It was a cooperation between Children's Hospital and University Hospital. It's called convalescent plasma infusion. So you take a patient who has recovered, you measure their antibodies to the coronavirus in their blood tests, and if they have a lot of antibodies, you take that serum, concentrate that in the plasma, separate it from the blood cells, and then give it in an IV infusion to infected patients. Some case series also suggest that it's very effective, but to date, we only have one small randomized controlled trial from China, which did not show that it was effective, although the small case series did. We'll see if this shows to be effective. So what about vaccines? Where are we with vaccines? Well, you need to understand we're going at unprecedented speeds at getting vaccines for this with good reason. Usually it takes 6 to 10 years to develop a vaccine when we know an infection is problematic. So phase 1 vaccines have already started, and they started early on in our surge in Washington and other places, where phase 1 is you give it to a small number of people and just see, do they make antibodies, protein against the virus? That's phase 1. Then if it looks positive that it is causing people to make antibodies, then they do what's called phase 2 studies, where they have a much larger sample size and they see, is it safe? It takes a lot more people to get the vaccine to see if we're going to get side effects. So I just learned last week here at UC Health, UC Health is going to be involved in a phase 2 study of a vaccine starting in July, where they're going to enroll about 1,000 people from Colorado to look to see, is it safe? And again, to confirm, do these people, most of the people, make antibodies? Is it efficacious? Then it's unclear to me on how our country, the world, is going to grapple with this. Are we going to do phase 3 studies? Phase 3 studies then show, is it efficacious? Meaning, all right, there's surrogate endpoints that they make antibodies, but does it really prevent infection? I think the world is so anxious to get a vaccine that phase 3 may be giving it to as many people as possible. If we know a certain vaccine is being safe. They're looking at, there's well over 10 vaccines that are being studied to see if one's not helpful, hopefully the others were. And Anthony Fauci said at least 2 of them are looking very promising. So it remains to be seen how these are going to be unleashed in the fall. So in summary, the spread of COVID in Colorado continues to decline, but the decline has slowed because of recent decrease in social distancing. And this is prior to the citywide demonstrations and protests. We won't know what impact that'll have on spread of the infection in our community until about 2 weeks, based on how we know the latency of infection. Um, with the signals showing slowing of the decline in cases, many worry that with the recent large gatherings, this will be a problem in about 3 weeks. Through evidence of healthcare facilities with multiple steps taking, we can prevent spread, and in some ways we can gather, but we still don't have um, absolute understanding. Current models are showing worrisome spread of the infection by September. And there's a chance we may need to revert back to stay at home or in the Episcopal Church season 1 if that occurs. Okay. So I'll try to end my screen share.
Dr. Joe, thank you for this presentation and for outlining such a complex topic, but in a way that gives a really detailed example of where we are as the state of Colorado in this manner. It is now 3 o'clock, and I want to devote the next 30 minutes to questions, comments for Dr. Joe on this topic. Because we are a manageable group, feel free to raise your hand and we can call upon you. If you have a question, if you want to type it out, you also can use the chat function on your computer. But are there any questions folks have? I see Dee waving her hand. Dee, I'm going to unmute you. If you can unmute yourself and feel free to ask Dr. Joe your question. Okay, you're unmute, but we still can't hear you, Dee. Well, Dee, are you able to see the chat box in your on your computer? There's a chat button. If you want, you can type in your question in that chat box and we will be sure to get to it. Okay. All right. While Dee is typing that question, is there anyone else who would like to get us started? Yes, Marty, go ahead and unmute yourself.
Hello. Am I getting out there?
Yes, we can hear you.
Yes.
Thank you very much, Dr. Joe. That was very interesting. I didn't realize, just looking at your statistics, that from age 60 to above is 90% of the fatalities. And I wonder if there's some way to modify how we do quarantine based on age, if that would make any sense, would be my first question. My second question is, there's a well-known cardiologist in Denver named Boone, who is prescribing chloroquine for patients of like me, my age, and hustling along with it, comorbidities. My own physician said it's not worth the trouble. How do you evaluate that yourself? Would you, if your dad was here and was in my condition, would you pre-medicate him for this? And thank you very much.
Yeah, great question. So your first question, should we modify the stay-at-home orders based on age? Yeah, and that's what the School of Public Health is suggesting as a possibility. We all have our own thresholds of risk. Some are very risk averse. Some don't want to be told what to do. So it's it runs a spectrum in between. And certainly those to avoid early death and severe infection, those older than 60 should be very, very cautious about their social contacts over the next year or so. What they feel is an acceptable risk of going on in the community. To your second question regarding chloroquine, no, I would not. The data, there's multiple trials not all very good, but there's multiple trials on chloroquine that have suggested the risks outweigh the benefits. And with any therapy, there's risks. And it looks like the risks probably outweigh the benefits. So I would not recommend prophylactic use of chloroquine.
Thank you, Marty. Dee was able to type in her question along with a hearty greeting from the University of Michigan, Go Blue. What is your opinion concerning ventilators?
Oh boy, I wish I could look at the question a little bit more, Dee. So I'll talk about as much about ventilators as much as I can. They're critically important. I don't know what our capacity is. I know there's been efforts to increase manufacturing of ventilators, so we have a stockpile for the repeat surges, and many of the hospitals have converted wards into intensive care where nurses and physicians can care for patients on ventilators. But I don't know how our numbers have changed in Colorado over the last few months. So if it's the number you're asking, I don't know. If it's if you need it, you need it. And there's actually very specific ways ICU doctors have learned to care for these patients on ventilators, where they what do we call proning patients, and even proning them before they need to get on the ventilator. So it's critically important.
Okay, thank you, Dr. Is there another question in our group today? Dick, go ahead. You have the floor.
Yep. My question is, I was sick with pretty much all the symptoms that they talk about back in February. And I was wondering if the current tests that are available would indicate whether or not that had been COVID. And
Sure.
The second part of that question is, if so, how would I get a test?
Sure. So with some degree of accuracy, I think the test would show whether you were exposed or not. And University Hospital and National Jewish Hospital, probably other hospitals in our metro area, have the ability to just get the test done. It costs about $100, and you can pay out of pocket, or insurance may cover, and you don't need a doctor's order to get the test. You can just go. If you're a patient at University Hospital, you don't need to ask your doctor's permission. You can just schedule it through this app that they have called My Health Connect and order it, and it'll be $100. A little extension of your question, considering the timing that you were ill, I suspect you probably didn't have the infection, unless you were traveling outside of the state, particularly abroad. This was a bad viral year for other infections, particularly influenza, but other infections that mimic COVID. So unless you traveled out, I've had a number of some of my patients who felt like they had COVID around the same time frame, got the antibody tests, and the antibody tests were negative. Another thing is even if the antibody tests were positive, we don't know that means you're protected from this virus.
Right.
There's some viral infections, I think dengue is one, where people are more sick the second time they get the infection because their immune system goes on. So we don't know what repeat infection, if antibodies. Now we think based on other coronaviruses, it gives protection, but we don't know that.
Thank you.
Okay, thank you.
I need to unmute myself. Thank you for that question. Our next question is from our chat, from Nancy, who asks, would you risk going on an international trip to Europe this summer, or is it super high risk in your opinion?
It's a very personal decision. It's certainly much more risk than staying in Denver or driving to low infectious areas. So it certainly puts you at increased risk. But is that risk super high? I don't know. I've had people ask, can I let my kids hug their grandparents? And I said, that's a personal question. You know, if let's say your grandparents die in the next year, what's worse, not having ever hugged your grandkids or getting the infection? It's a personal decision of risk. There are ways to minimize infection with air travel. I don't know if that was you, Roy, at our last video conferences that said it, but somebody on of that said that if you turn up the air vents and continuously blow that on you, that's going to be sterilized air that's forcing away. And also, if you're in the back of the plane, where you're not going to be exposed to as many people except for the bathroom, the window seat, so you're further from the aisle. But it's still the lack of social distancing at the airports, at both airports, and depending upon the prevalence of the illness in that country in Europe. So it's certainly not without some risk.
Okay. Thank you, Dr. Joe. I'm going to go to now Sandy Blake, and then we'll go back to the chat. Sandy, go ahead and unmute yourself.
Yes, my Houston family is intentionally having groups of teenagers. These kids are high school graduates that are wanting to party, intentionally having them expose each other like my mother did way back in the 50s when, you know, it was popular to do that. And I don't know what to think of that. And a lot of these kids are headed for college in September, which will be a danger time. But do you think that this herd immunity movement, especially among the young, it has any value in the overall picture?
I wouldn't say it's without value. And as you alluded to, it's not without precedence. The only way the infection will stop spreading is if we have the herd immunity. But the concern is who are they going to be exposed to? If they're exposing to each other, are they not going to be exposed to anyone over 50 or 60? And even if they're not going to be exposed to anyone over 50 or 60, how many people, 30 or 40, are they going to be affecting that are going to be exposed to those that are 50 and 60? So it's the spread in the communities that we need to control. So it's one thing if you had a bunch of 20-year-olds being isolated in a commune and sending maybe 3 infected people in. Just a theoretical model. Let everybody get infected, but they stay there for 2 or 3 weeks. So now they're immune. Okay, but it's your neighbor that you don't know if you're affecting, and we need to be concerned about. And that's what's really concerning of those practices to me.
So these kids that are all going to go off and live in dorms, which are as intensive, I would say, as nursing homes and prisons.
Yeah.
What are we to expect in that situation?
Well, and that's why the School of Public Health Modeling suggests that this is a problem. I know a lot of college students chose to take a year off defer their admissions because of this, if they can't live on campus, which some of the campuses may choose. I can tell you, being a father of a Denver public school student, DPS has given the kids and the parents, through separate questionnaires, the option of how we're going to social distance in the fall. They're not going to have 5 days a week of classes. It can be from the same that we ended the school year with it's all online, to 2 days per week, where some kids are going into school, some are doing online, versus you do a week on and a week off, alternating kids. So at least our public schools are developing strategies that they plan to implement to encourage some more degree of social distancing. I'm not sure what the universities are going to do.
Thank you for the question. I'm going to now the chat. Next question is, have you read any of the studies regarding vitamin D helping to provide protection of the virus?
I have not. And if Carol, if you want to share those with the group, I don't know about those at all.
Okay.
There's been a couple articles online, and there was also on Channel 4 about a month ago, there was a physician from Anschutz that was talking about that this was really, it certainly didn't avoid you getting it, but that there was a less chance, especially of you getting it, especially for older people. And I was just wondering if you'd had heard any of that.
Yeah. Now, I do have to say, vitamin D is an important thing that most Americans are undertreated with or don't have enough. And there's multiple organs in our body, not just our skeleton and muscles that need vitamin D, but our heart and so forth. And so it's become a bigger practice in my group to routinely screen vitamin D deficiency and supplement it. So, but I'm not sure how it interacts with infection with the virus.
Okay, thank you.
Thank you for that question. Also in the checks box, the question was asked, has there been any discussion about once a vaccine has been approved and produced, how will it then be distributed?
Not that I've learned, but that is one of the biggest challenges, is identifying which is safe and effective based on the surrogacy, and then mass producing that. And that's the challenge of because normally a vaccine would be 2 or 3 years in trials to see if it's effective before it's mass produced. And we're not going to know if it's really effective at preventing infection until it's out there. So it's a great question, bridging politics, economics, and healthcare on how you get this mass produced.
Wonderful. Now going back to video, Marty, I see your hand raised. Do you have a question?
Well, no, just sort of cogent, sort of flowing with this. I saw a news report on the television that AstraZeneca had a vaccine in progress, and they were also going and testing, and they were also ramping up to make 330 million doses by the end of the year. And that's, you might talk about what that's kind of a leap, but if they had 330 million doses, we wouldn't have to worry about it. And thank you.
Yeah.
Any other questions from our group? Another question has come in through chat. Given that the virus can survive on cardboard for up to 24 hours and on hard surfaces for longer, should we still be disinfecting our groceries and other items that come into our homes?
Yeah, probably. I was doing that early on in the pandemic, and I have to admit we've relaxed on that, for good or bad. And I think this is the challenge that our whole society is going through. Are we relaxing practices too quickly? It's not a bad idea to cleanse them, and but it's also the availability of the wipes to clean it. You know, cardboard surfaces, you're going to ruin it with water and soap. If you have disinfection wipes, sure, those would work. So plastic containers, sure, you can use water and soap, but it's not a bad idea. If you have the time, I would recommend.
Thank you. I see Roy has a question. Roy, go ahead and unmute yourself.
Yes, I want to talk about the issue of case identification and tracing.
Mm-hmm.
It seems like that varies by county, what capacity they might have. I came from a county in North Carolina in March, Dare County, and so far they've had about 40 cases, population of 40,000. So they're doing a pretty good job on this arena. Obviously, it's different than Denver, but even in Colorado, there must be some counties that can accomplish it. What's your thought about how good would we have to be to make it work in a larger county?
Yeah, great question. I don't know the numbers relative to the population density of how many. Regarding contact tracing, what I had heard early in the pandemic, and I said I think on my first one of these, was an interesting app that Apple and Android had collaborated on to allow contact tracing while still keeping people's identity secure. And I've learned when I've looked into this, what happened to this, that it's just not going to be released in the United States because of personal privacy. Other countries have adapted it. I don't know if it was Spain, some European countries, but certainly Singapore, North Korea, and Japan. They have all adopted this. And so how it works is if you get a test for COVID, you have to get this app and register yourself. And if it's positive, it looks at where you've been for the last 24 hours and shoots out texts to everybody who's been in that area saying there was someone that was infected at that area at this time. And so it allows people to then quarantine on a much larger scale based on exposure in contact. And it worked. You know, it worked in Singapore, except for Singapore had a similar problem that we had in the United States with the socioeconomic divide, where they had a large migrant group that had gotten mass infected. And so most of the higher wealth in Singapore stayed healthy, but there's an epidemic in that. But in China, they have very, if you want to use draconian measures of isolating people, and it worked. I don't think the United States population would agree to that. But even in countries such as Japan, it works. The technology would work, but it's what people perceive as giving up their personal freedoms. But I don't know about how much contact tracing per county you need. And just the comment that I want to make to our group, I just learned on the news yesterday, North Carolina, as you were just mentioning, Roy, 3 states are showing an increase in infection rate now. North Carolina being one of them, Utah and Arizona being the other 2. there's also a fairly high number in some counties in Nebraska. So we're talking, and I just learned from one of my patients in Wyoming on the reservations in Wyoming, there's a high number of cases spreading. So in states around us, there's increasing numbers. So just because.
Thank you. Other questions for maybe those who have not yet asked a question? Okay, and that's returning to the topic of sanitizing groceries. We have a question of wondering about the effectiveness of bathing groceries in Clorox mixture, and what is the percentage of Clorox to water that you would recommend?
I wish I knew, Sandy. Good question. I don't know. And as long as that chlorine isn't getting into your food. So it depends on the, I do think those answers are readily available online. I just don't know them.
I see Roy has his hand. Roy, you have something to contribute?
Yeah, I think on the Clorox bottle, it has a formula for purifying water, and you might double it. I don't think I'd do much more than that, but there is a formula on the bottle.
Okay, thank you. Any other questions for Dr. Joe? If not, I have a final one, Dr. Joe. First of all, thank you for your time with us and for breaking down the numbers that can be so overwhelming into a way that we, as within a particular context, in a place, to be able to understand. So thank you. My question is, knowing all of the data that you have been basically living in over the course of several months now, in where we are now, what gives you hope and what causes the most concern based on what you know about COVID-19 at this moment?
What gives me the most hope is that there's a lot of people who are diligently trying to understand and help us evolve quickly. And that I truly believe most people are inherently good and are concerned about our neighbors. Yes, we always see bad apples or people that allow themselves to be sucked into anger or self-focused approaches. What gives me hope is that I used to get angry myself seeing people outside, particularly in the grocery store, without a mask. Because to me, that was telling me you don't care about your neighbors getting sick. And that made me sad and angry at the same time. But more and more people are wearing masks. And so I do think most of our neighbors care. Certainly in our church community, I believe that's true. It's the core of who we are as Christians. And certainly our Muslim and Jewish brothers and sisters as well. What makes me scared though is that if there's enough people that are going to disregard the social distancing and these things such as masks, that's going to allow it to spread. And I mean, we got to be honest, economically, we need to open up. Many businesses are going under, and that's going to lead to significant hardships. And there's an economic drive to expand and open up, and I get it. I myself, I'm fortunate, I'm in the healthcare field, so I think my job is stable. But I had to take a pay cut because our institution is losing millions of dollars. So I get the economic impact of what's going on. But I think in season 2 in our church, I think we can do this safely. if we all work together. And it's not going to be for everybody. It shouldn't be for everybody. In some way, it will be. But I think most of us want to work together, and we're not of the mindset, leave me alone. I want to do what I want to do.
Thank you, Dr. I love what you just said, that for this to be successful as a church to return, that we all have to be in this together. And it takes all of us sort of making a covenant of we are going to keep one another safe, even if it means worshiping in a different way. Thank you for making that connection that it requires all of us. I want to thank all of you for being here this afternoon. Our conversation around regathering will continue on Sunday, June 14th, where our regathering task force, on which Dr. Joe is a member, will be presenting the results of our congregational survey. We had over 124 folks, or 124 folks in particular, fill out that survey, and we want to share with you the results about the attitudes of our congregation toward this topic. And we are taking the survey along with the science and the data of the COVID-19 spread in Colorado, and all of these are pieces of a puzzle that will allow St. Luke's to discern and plan what will be our response in this next phase in order to keep folks safe and also to provide spaces for people to worship. You all got the best part of the medical slideshow for Sunday. So you'll be able to answer questions that other folks may have when we are at the conclusion of our survey presentation on Sunday. But I'm so thankful we could carve out this time for Dr. Joe to really get into the data of what we are dealing with at this time. So with that, Reverend Sandy, would you mind closing us in prayer on this day?
Lord God, we are your people. We care about each other. We care about the people that are not in our community. And we ask that you will lead us and that your Spirit will direct us in our interchanges with each other in the future and our caring for each other. And we offer thanks for those in our community who are vigilant and who are trying their darndest to make our community work well in this pandemic. We ask that your Spirit will spread over the world and that this will be a time of transition into something that is even better than where we are coming from. We ask in Jesus' name, amen.
Amen. Thank you so much, Dr. Joe. A copy of today's session along with Dr. Joe's slides will be available in the Friday email. And until we can gather again, go in peace. Thank you all. Bye-bye, everyone.